People do those sort of studies. They also often try to simulate types of injuries that then happen to humans. I have a recollection of people using pigs for the same reason, particularly in the context of gunshot wounds or fast impact wounds, which get simulated. Nobody shoots at pigs, just to be clear.
Charge up your axons, ready your receptors, and shift your lobes into upper beta phase. You are listening to Smart Drug Smarts, the podcast dedicated to helping you optimize your brain with the latest breakthroughs in neuroscience, nootropics, and psychopharmacology.
Hello and welcome to Smart Drug Smarts. My name is Jesse Lawler. I am your host, and this is the 152nd episode of this podcast dedicated to the ongoing betterment, or in some cases, just the preservation of your own brain by any and all means at your disposal. I mentioned preservation specifically this time because in this episode, we're not going to be talking about any way of making your brain better, but instead specifically what happens when your brain gets banged up and some things that you might be able to do prophylactically, therapeutically, or at least understandingly, should you or somebody that you love be one of the millions of people annually to deal with traumatic brain injury. So we're going to be talking about TBI, the handy if not terribly endearing acronym for traumatic brain injury in this episode. This is our Halloween episode, and it seemed like TBI would be a good brain relevant and yet kind of scary topic. We're actually going to be doing a double-decker interview this week. We've got two experts, both of whom have a lot to say about TBI, Dr. Martin Monti and Dr. Kathleen Bell, both of whom I will introduce with the appropriate fanfare in the main interview. If you hang around until the very end of the episode in the Ruthless Listener Retention gimmick, I'm going to tell you about a recent finding on a new and improved way to tell after the fact if a concussive injury has actually occurred, more easy, accurate, and non-invasive than has previously been possible. That'll be at the very end, so you'll need to wait around for that. But right now, let's kick things off as usual with This Week in Neuroscience. And like I said, happy Halloween.
Smart Drug Smarts, This Week in Neuroscience.
So we've talked in previous episodes about neurofeedback, which is accomplished by reading brainwaves through one means or another, and then giving it super low latency feedback, low latency meaning very, very fast feedback, as to what's going on in the brain, back to that brain's owner through some perceptual form. This could be alterations to a video that they're watching or to sound that they're listening to, but providing something that we normally don't have, which is a real-time cue of exactly what is going on within our brain as it's happening. And the upshot of all this is that if some aspect of our brain seems to be working at odds with itself, imagine your right hand arm wrestling your left hand and you're not actually aware of it. Neurofeedback kind of gives visibility to some of that inner tension in a way that allows the brain to relieve some of those tensions, realize what's going on, and potentially find a workaround. All of this rather amazingly happening subconsciously. Now, the problem with all this is one of the bottlenecks with neurofeedback is getting an accurate reading of what's going on within the brain. And the brain is fairly big as organs go. It's got a skull around it. Some of us have legitimate issues with invasive appliances being installed into our brains. And so typically the data gathering about what's going on within the brain takes place using electrodes on the outside of the skull. And so while we can get a pretty good picture of what's going on in the outer parts of the brain, some of the deeper brain systems that are packed way down inside the skull, it's harder to get a direct signal. You've got more distance to cover and more other flesh that's in the way. So you're kind of trying to triangulate information, get what's going on deep within the brain, and that can be tough. However, some of our most important brain regions are actually packed pretty deeply in there. One example that comes to mind is the amygdala. The amygdala is an old and deeply buried set of neurons, kind of the shape of an almond, and it has a lot to do with the regulation of emotion, particularly the real fight or flight emotions. Some of those emotions that if you're dealing with anger management issues, what my mom would always call flying into a terrible rage, it would maybe be nice to be able to do a little bit of amygdala-focused neurofeedback. Now, typically when researchers look at the amygdala, they're using fMRI, functional magnetic resonance imaging, which really isn't an ideal technology for this because it pretty much requires going into a clinician's office. Accessibility's bad, price is high, but a team of researchers earlier this year at Tel Aviv University have found a new imaging technique that uses EEG, electroencephalography, to accurately gather real-time information on amygdala activity. Says the senior author of the study, Talma Handler, the major advancement of this new tool is the ability to use a low-cost and accessible imaging method to depict deeply located brain activity. The team used the new tool to train 42 participants to reduce an auditory neurofeedback signal that was indicative of their overall level of amygdala activity. Corroborating fMRI studies also suggested that the neurofeedback task led to a reduction in the regional activity of the amygdala. Then an additional experiment conducted by Handler's team put 40 participants through a behavioral task that tested emotional processing in the amygdala. The data revealed that the study's participants were able to down-regulate their amygdala activity to control the way that their emotions manifested in actual behavior. Says John Crystal, the editor of Biological Psychiatry, it's an exciting idea that perhaps direct feedback on the level of the activity of the amygdala can be used to help people gain control of their emotional responses.
Smart Drug Smarts, the podcast so smart we have smart in our title. Twice.
Going into the international grab bag of iTunes reviews, Sarah again from the UK says, "Great find. I only just discovered podcasts, and this is in my top 2 straight away. Great guests, fast pace, and a few interesting facts in each episode." And Chad Grills from the USA says, "If you listen and apply this information, this is without a doubt the most valuable podcast on all of iTunes." That is high praise indeed. Thank you, Chad. Thank you, Sarah. And thanks to everybody that's been leaving reviews. I've been planning on doing a traumatic brain injury episode, which this one is, for quite some time, and I'll kind of pluck links when I find interesting stuff and kind of save them for a future episode. And a long time ago, this was like something that I was like, wow, I wish this existed. And I told a friend about it, and then a while ago got a link that, hey, that thing you mentioned actually does exist. I don't own one of these things. I've never used it, so I'm not really vouching for it, but it's pretty awesome. And since it relates directly to traumatic brain injury or the avoidance thereof, we'll put a link to this up. This is something called Hovding. I'm going to guess this is a Danish company or somewhere up in the Scandinavian part of the world. But what this is an airbag for urban cyclists. So if you're like me, you ride your bicycle around a lot, stand a significant chance of getting run over, and you kind of wish you could have the protection of an airbag minus the car that typically goes along with it. This thing, which retails for about 300 euros, it is kind of like a deflated hood. Think of it like a big collar, like maybe, Dracula would have on his cape or something. But in the case of sudden impact, if it realizes based on an accelerometer, you're not going in a straight line anymore, you've been jostled from your bike, you're about to hit the pavement, then in true airbag fashion, this collar thing quickly expands into like a big padded enclosure for your head. Much bigger than a traditional bicycle helmet. You can almost think of one of those super bonnets that like a strawberry shortcake character would wear, scaled up to the size of a human adult. They've got some videos on their website showing this thing in action. It is pretty cool. But if you do a lot of bicycle riding, either off-road or on dangerous roads, this might be worth looking into. Pretty cool idea. Again, I've got no financial interest in this thing. I just kind of wanted to put it out there because it's neat and it's TBI relevant. Something where I definitely do have a vested financial interest, I am not ashamed to say. In fact, I'm proud to say, is Axon Labs, where we've got a couple of stacks. Nexus and Mitogen, if you're a longtime Smart Drug Smarts listener, you've certainly heard me talking about these before. Nexus is a cognitive stack based around aniracetam, CDP-choline, phosphatidylserine, and pycnogenol, all of which are worth knowing about in their own right. But if you're a fan of efficiency, you want all this in one place, Nexus is a great way to get those. Similar story with our mitochondrial stack Mitogen. More ingredients, many difficult to pronounce, but all worth it for your body. Mitochondria, the energy power plants of your cells, present in every single last cell of your body, but particularly in brain cells, your digestive tract, skeletal muscles, the kind of cells that have a lot of energy requirements. Mitogen can be a major energy booster, well worth checking out if you haven't done so yet. You can find both of those over at axonlabs.io on the web, or if you're already lurking around smartdrugsmarts.com, check out the shop link and you can click over from there. And I've gotten back on the horse with Brain Breakfast publication. The Brain Breakfast is our weekly newsletter. I always say weekly with a grain of salt because that's a bit of a euphemistic deadline. But if you're curious about stuff going on behind the scenes in Smart Drug Smarts, also getting a bit of a scattergram of what's going on in the world of neuroscience, you can find a lot of those links in the Brain Breakfast, and you can sign up for that at smartdrugsmarts.com/newsletter. As mentioned, this is the Halloween episode. Hope that you're looking forward to a safe and happy Halloween. If you have any really awesome Halloween costumes, definitely feel free to email those my way. But either way, be safe, watch out for too much processed sugar in the candy, and too much damage to the liver, depending on what sort of Halloween partying you're into. But I think that's it for the news and updates, so let's jump ahead now to the main interview.
Smart Drug Smarts.
Okay, so as mentioned in this episode, we're going to be talking about kind of a gnarly topic, traumatic brain injury. But perhaps because it is such a gnarly topic, if I'm allowed to say gnarly in what is ostensibly a science podcast, that just makes it all the more worth talking about, because TBI, as it's called, is something that affects a large number of people, millions of people per year in the US. And those are just the cases we know about, which really might be just the tip of an even larger iceberg. While shaking the academic tree for this episode, trying to find relevant experts, hat tip to Michelle on the Smart Drug Smarts team. She actually found a couple of people, neither of whom did we want to pass up. And so what you're going to get here is actually a cross-cut interview between Doctors Martin Monti of UCLA and Dr. Kathleen Bell from UT Southwestern. So you'll be hearing two voices in this episode. One is a man, one is a woman. I leave it to you to guess who is who, but each of them have both interest and professional expertise on the brain and what happens when it gets jostled around, resulting in the physical impact injuries that characterize TBI. Dr. Monti's work is closely focused around the study of consciousness, what it means to be conscious, and what defines semi-consciousness states, whether somebody is fully conscious, in a coma and unresponsive, or somewhere in between, defining what some of those in-between states look like. And Dr. Kathleen Bell, MD, is a neurorehabilitation specialist and the chair of the Department of Physical Medicine and Rehabilitation at UT Southwestern Medical Center. She also holds the Kimberly-Clark Distinguished Chair in Mobility Research. So dealing with TBI, its aftermath, therapy, and rehabilitation is pretty much her stock in trade. So between these two perspectives, a lot of information here. Knock on wood that neither you nor anyone close to you will be dealing with a traumatic brain injury, but forewarned is forearmed. So let's jump in with Drs. Monti and Kathleen Bell.
I guess sometimes I'm surprised at the level of worry that people have about relatively minor things that are just going to happen and are part of life. I sometimes will see people who get up out of their chair and they bang their head on the kitchen cabinet. They're at their doctor's office the next day because they're really worried that they've done themselves some kind of damage. And, I think that there's all ranges of brain injuries. There's certainly some rules of thumb. I mean, if you whack yourself in the head and you lose consciousness, you need to get that checked out. That's pretty much a no-brainer. If you have a period after you hit your head where you really are confused or you're not remembering things or you're acting funny. And sometimes people don't realize that themselves, and it takes someone else to say, that person's acting funny. People sometimes, when they've gotten a good concussion, really don't realize that they're not remembering things correctly or that they're acting in a peculiar manner. But teammates might notice, their parents might notice, someone else at the job might notice. It's that sort of feedback that sometimes is really helpful for people.
Consciousness is one of those mysterious things where we all seem to have a feeling or an appreciation for what it might mean. But when you speak with different people with different backgrounds and different interests, they often are thinking of slightly different shades of the same thing. So when I speak of consciousness, and here I'm citing a famous Italian neuroscientist called Giulio Tononi, I think of consciousness as that thing that disappears when we fall asleep or when we fall unconscious, particularly if we fall into dreamless sleep, and the thing that comes back either when you have a dream or when you're awake again. So in the broadest sense, it's that feeling of experiencing the world around us. We experience the sounds around us, the sights, this general feeling of experiencing what's happening to us. I think we can take that to be a very broad view of what consciousness might be. And look, in daily life, we spend most of our times either we walk around, we work, we speak with people, or out. We're asleep and not dreaming, maybe undergoing anesthesia. And this just makes it easier to think about it. The truth, of course, is that if you really think hard, consciousness is a spectrum. So you might be completely out, you might be unconscious, maybe in a coma or undergoing general anesthesia, maybe for surgery. But then think of things such as light anesthesia. You're groggy, you're not fully with it. Or think of sleep. You're more or less deeply asleep, and the extent to which you truly are conscious is less than maybe, right now when you're focusing on something. And even just if you're hypnotized in front of the TV, that's bound to be a different type of consciousness than when you're very aware of what's happening around you. So it definitely is a continuum, which also makes it so hard because now we have to understand where exactly are we, or where is someone along this continuum.
Sleepwalking seems like it's sort of an example of the kind of thing you're talking about, where somebody could be up and around, walking, doing complicated stuff, but not actually experiencing their own behavior.
Absolutely. So here, you, me, the people listening to us, the standard way of thinking of consciousness is that you're either out and about and moving and conscious, or you're not moving and unconscious. And this kind of works most of the times, until you start thinking of those complicated scenarios where you're doing one of the two things but not the other. In sleepwalking, you are walking and you are deambulating, you're doing behaviors that might be fairly complex, but you don't quite match the level of experience that you're having. And dreaming is another one. You're clearly not awake, right? You're asleep, and yet conscious.
Normally, I try not to take my neuroscience cues from Looney Tunes, but in this case, I feel obliged to ask. When cartoon characters get whacked in the head, they see spinning stars, tweeting birds, things like that. Does that ever actually happen where there will be a direct perceptual change, almost hallucinatory, as a result of a traumatic brain injury?
Now, I don't know about the singing birds. I'm not sure I've ever heard anybody talk about singing birds, but absolutely people will talk about seeing stars, and that, often means that their vision changed abruptly for a period period of time. People may see wavy lines. People may hear things differently. So absolutely, perception can be altered after a concussion.
Would that be a case where you absolutely should go to a doctor and get it checked out if you do have perceptual effects you notice?
The things that are absolutely see the doctor sorts of symptoms are if you're vomiting or nauseated, if you have any change in your vision, if you notice that you have any kind of weakness in your arms and legs. Obviously, if you have a seizure, you would want to see a physician. You would want to actually go to an emergency room under those circumstances. So if you have any of those neurological signs, you would want to see someone. If you have an unusual headache that either gets worse or doesn't resolve with usual methods, taking a Tylenol or something, then that would be a reason to get checked out as well.
When people sometimes do feel nauseous, or you mentioned vomiting from a traumatic brain injury, is that a case of your body thinking that because the brain isn't operating correctly, like maybe you've been poisoned and thinking it needs to eject poison from the system, sort of misdiagnosing what the problem is?
There's probably one of two things happening. The first thing is that with a concussive force, you can get some disturbance to the inner ear. And the inner ear is what helps you with balance and being able to maintain your adaptation to changes in balance or changes in what you're seeing in moving objects. So you really could be having the equivalent of being car sick when you're not moving if you get enough of a concussive blow to your inner ear. So that's one of the things that might be going on, is that you might have at least a momentary effect of your inner ear function. And the other thing is that if you do have some neuronal damage, you do cause a change in the chemical environment in your brain, and it could be that that then stimulates neural centers in your brain that kind of say you're sick to your stomach and makes you feel nauseated and vomit. So it's probably not so much the ejecting poison as the fact that you have a change to the input to your brain that is telling it that there's something off.
Speaking specifically about traumatic brain injury cases, is it something where you take a hard hit to the head? Are you going to see the bad effects pretty much immediately, or is it something where the full extent of the consciousness damage might not be apparent for hours or days?
So that's very interesting. So usually after a severe brain injury, individuals lose consciousness right away. So for example, when they arrive to our center, they usually are in a coma. At that point, we also keep them in a chemical coma for 1-2 weeks, whatever is necessary for the neurosurgeons to reduce not only what is called the primary damage, right, the impact, but also to reduce further damage. Just a simple example is if you hit the brain will swell. And of course, your skull is preventing the brain from expanding as it swells. Right. And so now things are getting compressed and stop working. That's why the first 2 weeks are usually employed to avoid any further damage. Once we stop the induced coma, some patients actually recover consciousness rather quickly. Within a few days, they've recovered consciousness, they're talking, they are understanding what's happening around them. Maybe by a month, they start trying to walk again. Other patients, however, and this is the mystery, they don't. And it's not the induced coma, and we're still left to understand why.
I hesitate to ask this question because I can just imagine people thinking I'm a much more terrible person than I am, but this seems like a case where animal studies, essentially hitting animals in the head and seeing what happens. I mean, that's the kind of thing you could never do in a human study, but could conceivably be really helpful in trying to sort out how to deal with traumatic brain injury cases. Is that the kind of study that gets done? Are there a lot of rats being pummeled about the head by researchers somewhere?
Yes, people do those sort of studies. There are a number of models that are employed, for example, in mice or in rats. People try to vary the type of injury, and they also often try to simulate the types of injuries that then happen to humans. I have a recollection of people using pigs for the same reason, particularly in the context of gunshot wounds or sort of fast impact wounds, which get simulated. Nobody shoots at pigs, just to be clear. But they do get induced injuries through sort of fast-moving objects or compressed air. And so people use these kind of models to understand at a more chemical and at a more invasive way what are the processes that happen after brain injury. In a slightly different context, this type of research in animals has been crucial to understand the phenomenon of concussion. For example, the fact that once you have had one concussion, if you have a second one within a brief interval, the damage can be much, much greater than just having that same concussion, but not shortly after another one.
One of the things we know about time periods, we know, for instance, that there's a critical time period after a brain injury in which a second brain injury can be disastrous, especially in children.
How long does that period last, that period of extra danger?
We know for certain it's during the period where they continue to be symptomatic. But what we're finding out about young people and young athletes is that even when they become asymptomatic, their brain has not returned entirely to normal functioning. So with a lot of the imaging techniques that we're able to use right now, we can see that even when someone, for instance, is testing normally on computer test or paper and pencil tests, that if we look at their brain function while they're doing that, they're not as efficient as they were before or as somebody who doesn't have a concussion is.
When you talk about efficiency there, are you talking about the speed at which questions get correctly answered, or is this actually something where even the speed's the same, but you can see on an fMRI more blood flow is required to accomplish the same results?
That's exactly what you see. What you see is that more brain real estate is involved in solving those problems. Now, eventually, again, with a concussion or a milder brain injury, you reestablish that efficient use of your brain. People who have moderate to severe brain injuries may never recover that efficiency that they had before. That may be one of the reasons that people talk about fatigue, cognitive fatigue, after they've had a concussion or a brain injury.
I know that a lot of your recent work has been dealing with people who have lost consciousness, trying to find out how to revive them effectively. Tell us about that.
So a lot of my work in the past 10, 12 years has really focused on understanding how do billions of neurons and trillions of connections somehow add up to, you, me, this person that is experiencing the world around them. Now, sometimes we lose this feeling of consciousness, and one case that I've been very interested in is what happens after severe brain injury. Maybe somebody has a very bad accident. We tend to see a lot of car accident survivors, for example, or gun wounds. Right. Other examples might be maybe somebody drowning and not having enough oxygen delivered to the brain. And so now somebody loses consciousness and enters a coma. Now, the question is, what happens after? Now that they're unconscious, how is this brain that until just a moment ago was producing consciousness suddenly unable to do so? And why? So we spent a lot of time trying to understand what brain mechanisms underlie the feeling of consciousness. And now that we're starting to get a grip on that, now we can answer the question, well, if we're starting to understand how the brain does consciousness, can we do something about it? And that's where this most recent research aimed at trying to help people recover consciousness after severe brain injury is coming from.
What are you expecting there as far as improvements to the way that we do things at the sort of the current standard of care?
I think today, for patients who are in a disorder of consciousness, so they've survived some terrible event and they failed to fully recover consciousness, we really don't have many alternatives in terms of treatment. What happens mostly to them is that either they recover spontaneously or there isn't much that we can do for them. There are some pharmaceutical treatments available, in fact one, and that seems to be very helpful. But other than that, if a patient doesn't recover, they enter this limbo where not much can be done.
There are some lines of work, soldiers, firefighters, race car drivers, things like that, where likelihood of sudden brain impact is always going to be greater than zero. For people that are in positions like that, is there anything prophylactically that a person could do to make their brain more likely to have a good recovery should they wind up with a TBI at some point?
I mean, there are certain standards that are pretty applicable to anybody, and that's don't smoke because you enhance your vascular disease if you smoke, and that includes your cerebrovascular system as well. So that's something to avoid. And the other thing is just to, really pay attention to things that impact brain health. Overuse of alcohol, overuse of marijuana, overuse of any drug can alter your brain significantly and alter your neurotransmitter and receptor profile in your brain. And all of those can impact your ability to function and to recover from injuries. Obviously, there's also the whole issue of nutrition and what sorts of things are healthy brain foods. And I think that really does have some impact on the vitality of your brain. And the last thing is probably regular exercise. We have a lot of good data to show that, a single bout of exercise will improve your cognitive abilities. It's pretty amazing. So being active really does help your brain as well as everything else. That's kind of, I guess, pretty common sense stuff.
What do we know about the difference in brain state between two people that have the same levels of physical capacity, but one has conscious awareness and the other doesn't? Do we know mechanistically within the brain what's going on to separate those two types of person?
This is the crucial question. And I can tell you that people have different hypotheses. For example, you might think that most of your cortex, the part of the brain, outside part of the brain, where the cell bodies are. So that's really where the you and me is happening. You could pull out individually one of these pieces of the brain and you and I would still be conscious. Just we couldn't quite experience certain aspects of our world. So it's very hard to narrow down one tiny piece of the brain and say, oh, this one right here. If you don't have this one, then you're unconscious. There certainly are parts of your brain that will make you unconscious. For example, a lesion to this very deep piece of the brain called the thalamus. A lesion in there will make you instantly unconscious. But that's not the same as saying that's where consciousness is.
What proportion of the population do you feel like at some point in their life has a non-trivial traumatic brain injury, whether they're aware of it or not?
That is a really great question, and it's a much harder question than you might think. We know from statistics from the Centers for Disease Control that about 2.5 million people a year in the United States are seen in a hospital or admitted to a hospital or die of a traumatic brain injury. So we know that's 2.5 million people. We don't know how many people go to their doctor's offices with a concussion because the Centers for Disease Control really have statistics primarily on hospitals. So it's millions of people every year that have a brain injury. Now, we know that probably as single episodes, 80% of those people will more than likely resolve to all intents and purposes entirely. And that means that functionally speaking, after a certain amount of time, maybe 3 weeks, they won't notice that there's any difference. The thing that makes that a little more difficult is if you have had previous injuries to your brain, like previous concussions, and have small insults to your brain that don't result in a functional problem, but if you accumulate enough of them over time, you might start seeing a problem. Or say you're someone who's maybe in their 60s and you have some subclinical vascular disease in your brain. You don't see that on a day-to-day basis, but it starts to accumulate, and then when you have a concussion or a brain injury on top of it, it's much worse than you would predict.
In the time just after a brain injury, does the brain do anything like pump out more BDNF to recognize that, hey, there's new neural pathways need to be laid down, now is the time to do it? Or could somebody theoretically, wait months or years and then come up with the workaround solution that they might have lost?
I would have a Nobel Prize tomorrow if I could tell you the exact answer to that. That is like one of the key questions that we're grappling with.
I think if you look at insurance statistics and actuarial tables, boys or men between the ages of 12 and 25 are by far the most accident-prone group. Does that demographic pretty much map right over to traumatic brain injury as well? Are those the likely danger candidates?
If you look at the epidemiology of TBI, you'll see that the highest incidence of traumatic brain injuries are indeed males between the ages of about 15 and 25, 15 and 26. There are two other peaks as well, however. There's the peak from 0 to 2, and then there's the peak above 70. And there are often different mechanisms that are involved in those injuries. So with young men, it tends to be motor vehicle accidents, sports-related injuries, and falls, whereas in the elderly, it's falls, and in children, it's falls and bicycle accidents.
It seems like it would be very easy if somebody was physically vegetative to shave their heads, put an EEG cap on them, and basically keep scanning their brain for activity until hopefully the moment at which they wake up. And then you can kind of do the before and after and see what brain systems are starting to come back online as they regain consciousness.
Let me frame it somewhat differently. Let's invent, you and I, a new device that can see everything in the brain, the little molecules that are exchanged from one neuron to the other, and we could look at every single neuron and every single synapse. And then, yes, you're right. Maybe we could just take 20 patients and monitor them 24 hours a day until they recover consciousness, and maybe we'll find what it is. What is that, one thing that is suddenly switching on and off? Of course, it's unlikely to be one thing, but there must be one aspect of brain function that suddenly vanishes or comes back.
Right.
But now we have to be back, unfortunately, in the real world, and all the tools that we have at our disposal are somewhat imperfect indicators of brain activity. EEG, for example, is great if you're trying to see the rhythm at which things work, but then you'd only be able to find the switch of consciousness if consciousness is really just about the rhythm.
If you could wave the magic wand of research dollars and set up exactly the type of experiment you'd like to run next, what would that be?
So it would actually not be very different from what you said earlier. We're trying to do a multi-time point assessment of patients, which just means we see patients here on the first day after severe brain injury. And what I think is a crucial missing piece of the puzzle is to understand what happens in that first month if I could see somebody every day and take an MR picture of them every day and an EEG picture of them every day. Is there anything that can help me predict who's going to be better and who's going to be worse? And in particular, if we can get a dynamic view of what happens over the first month, then we can really see and tell when is the right time for us to intervene with this new technology that we've created. I think we have a good understanding of what parts of the brain correlate generally with patients recovering versus non-recovering. And as I said, there's this one special piece of the brain called the thalamus, these sort of two little egg-shaped nuclei deep in the middle of your brain, which are, in a sense, a gateway of information, and also a pit stop that most information goes through when different parts of cortex speak to each other. The worse off that part of the brain is, the more likely it is that the patient will not recover after a severe brain injury. So that's why we are trying to intervene on that. But when exactly this happens is completely unclear. How much of the brain needs to be preserved for this to be effective? Completely unclear. At what time after injury, the injury in there becomes irreversible and cannot be helped with intervention? Completely unclear. Now that we're starting to get a general understanding of what does it take, or what does a brain that has a good outcome look like versus a brain that has a bad outcome, we really need to understand what are the boundaries, condition of this, and where can we do something about it.
One of the things that I find really fascinating is the occasional stories of what's called acquired savant syndrome, where somebody takes a hit to the head and then winds up being able to play the piano beautifully or something else. I mean, there's occasional but really profoundly weird stories about that. What are your thoughts on the potential mechanisms behind these stories?
Yeah, I'm not sure what to make of some of those stories. I think that when somebody has a traumatic brain injury, sometimes the change in the way they use their brain results in them being able to do something better. So, for instance, I have had a few patients who have, after their brain injury, acquired a certain small level of disinhibition that's really allowed them, for instance, to do better art. It's allowed them to, just be more expressive. So their art improved, their painting improved, or drawing improved. You can sometimes see people who have personality changes that might be positive. You certainly hear a lot about negative personality changes, but it does happen that there are times when people will actually acquire a sunnier disposition or will acquire more tolerance than they did before. So you can see some positive personality changes as well as negative. I'm not sure that I've seen anyone suddenly be able to play the piano if they had not played the piano before, anything like that. You do see occasionally some changes in language function, which is interesting. People who've been exposed to multiple languages throughout lifetime might have some alteration in terms of how well they speak languages. But, again, I don't know that it's not that they didn't speak a language before. It's just that they might change the way they speak the language. They might speak it better. But, I'm a little suspicious of stories of I never played the violin and had this brain injury and suddenly I could play the violin. That's hard to explain.
Do there tend to be differences in the outcomes on consciousness for various types of brain injuries? If I'm going to have something horrible happen to my brain, should I be rooting for one accident versus another?
Different individuals can sustain completely different impacts. Take car accidents, for example. One car accident is different than the other. Each of these patients is a snowflake. One patient gets a severe brain injury, maybe a traumatic brain injury to the front, one to the back, one to the side, and yet they all end up in the same unconscious state. Now, to the question that you are asking, usually there are two main kinds of brain injury. There's traumatic brain injury, the two paradigmatic examples, car versus pedestrian or gun wound, and there are non-traumatic brain injuries. So these are cases such as deprivation of oxygen or cardiovascular. For example, you might have a bleeding in the brain. That will also lead to a severe brain injury. Now, we do know, again, mysteriously, regardless of how different a brain injury can be, all these patients end up in a coma, and many of these patients will end up in a minimally conscious state or a vegetative state. So this is telling you that consciousness is not about the primary injury, but it's about something deeper of brain function. It turns out patients who have, for example, deprivation of oxygen, so-called anoxic brain injuries, they usually have the worst outcome outcomes. Not to say that if you've had a traumatic brain injury, you always have good outcomes. But as a group average, patients who have suffered from deprivation of oxygen typically have worse outcomes. And the reason for it is that those type of injuries tend to affect deep parts of the brain, the thalami. And that's why we think they tend to be less likely to recover consciousness.
Is there any reason to think of the sorts of repairs that take place in the brain following a TBI as being fundamentally different from the sorts of changes that take place during learning, like in a non-injury state?
That's an interesting question. The brain is all about learning. I mean, that's really what it's all about, whether it's learning traditionally what we think of learning or whether it's learning how to adapt your heart rate in response to what's happening in your legs. It's all learning. I mean, that's basically all our brain is, a learning machine. So I think that really what is happening after brain injury is new pathways of learning and new networks for supporting learning and memory and pattern recognition, even emotional learning. So I guess you could say it really is kind of learning. It's just developing new substrates for learning to occur on.
Something like the common cold, you've got viruses proliferating inside you. That's obviously not a good thing. We feel crummy and we don't want to go outside, feel physically weak. A lot of that has to do with an immune response by our body that basically makes us feel crummy on purpose so that we don't strain ourselves, but instead can just sort of marshal all our physiological resources for fighting the viral invader. I wonder if there might be potentially like a parallel with losing consciousness, where if your brain has taken a sudden hit, basically it's to an evolutionary advantage to not move around, to just stay still.
Absolutely. I've often had this conversation with my colleagues. The one thing we really do not understand is what is the meaning? Why would the brain enter a coma, vegetative state, a minimally conscious state? One view could be that the brain is sort of, to make an analogy to a computer, has booted itself up in a safe mode, right? To prevent further damage. It's functioning minimally so that you can go in and uninstall the program that created the conflict, metaphorically speaking. That's one possibility. Of course, the other obvious possibility is that simply, once the brain cannot function, it just shuts down and it's a limit. The brain just can't do any better. It's probably the medical consensus would be that. There's a fascinating question, however, of whether the brain does that to maybe preserve itself in some way. It is fascinating, the possibility that all these different types of brain injuries and mechanisms of brain injury all lead to the same outcome of unconsciousness. So that's why some people voice the idea that maybe it's a safe mode.
Where do you see progress being made in the next 5 to 10 years on the treatment of TBI? And that could be either immediate, like the injury has just happened, or long-term stages of recovery stuff. Do you anticipate breakthroughs on the near horizon?
I do. I see them in a couple of areas. As we tease apart this whole dilemma of what happens in the microenvironment of the brain, so we really tease apart this whole inflammation and neurotransmitter and good and the bad proteins that are deposited in the brain or formulated. As we start teasing that apart and we start being able to identify better each person's individual profile, which is one of the problems we have now. People just have a brain injury and all we can do is look and say, oh yeah, they have bleeding here or they don't have bleeding here. But if we're able to actually tease apart, how their brain is actually reacting, part of that has to do with their genetic profile, their epigenetic profile. That's going to give us tremendous information on how to use interventions more strategically. The other area that I really think that we're going to make a lot of progress on in the next upcoming years is this whole issue of neuromodulation, of being able to use either pharmacological means or electrical means or magnetic means to prepare the brain to make changes faster so that we can combine some of the traditional things we do in physical and speech and occupational therapy, combine those things with these jump starts to the brain to help the brain be more receptive and to make more rapid changes in a positive sense. So I do think we're going to see some really nice changes in that. I'm very, very optimistic.
Smart Drug Smarts.
So thank you so very much to both Doctors Monti and Kathleen Bell for their insight in those interviews. This is a really deep topic and possibly one that we'll return to in a couple of different ways. There is a really interesting and oddball stone that got left mostly unturned in this conversation, dealing with something called acquired savant syndrome, which is kind of like the Spider-Man version of traumatic brain injury, when something good can come out of what is ostensibly an injury. Obviously, this is the exception and not the rule. Should it even occur, it's subject to some skepticism and legitimately so when you hear some of these claims, but we'll probably return to acquired savant syndrome in a future episode because it's one of those things that's just, it's too weird not to follow up on. Also wanted to throw a line back to a previous Smart Drug Smarts episode when we've talked a little bit about the potential use of omega-3 fatty acids as sort of a prophylactic treatment against brain injury. Not that you can necessarily see a brain injury coming, and of course the best way to deal with such things is if you can see it coming, just to avoid that situation to begin with, but some lines of work probably put you much more in harm's way than others. And there's been some speculation that basically keeping your body souped up with plenty of omega-3 fatty acids might give the brain an easier time dealing with TBI should it occur in the immediate aftermath. I would direct you all the way back to episodes number 32 and 77 to catch up on some of the ideas there. That was a conversation with Dr. Michael Lewis. And as mentioned at the beginning, we're actually going to be keeping it on theme in the Ruthless Listener Retention Gimmick, still talking about stuff related to TBI, so let's just jump over there right now.
Smart Drug Smarts, Ruthless Listener Retention Gimmick.
So normally on this show, when we're talking about the blood-brain barrier, we're talking about interesting things that can pass through it and that can make their way into the brain through the blood. This might be the first time I can remember we're actually talking about something that's going the other way, something that starts within the brain, can pass out of the blood-brain barrier, make it into the bloodstream, and that's where things get interesting. In this case, it is a biomarker called glial fibrillary acidic protein, and according to a study published in the journal JAMA Neurology earlier this year, glial fibrillary acidic protein is a highly accurate biomarker indicating whether a concussion has occurred. A concussion is the most common but least serious type of brain injury. It can occur after a good whack on the head, but either way, not all whacks on the head lead to concussion, and so it is helpful to know if a concussion has occurred. As we just heard, after a brain injury takes place, the brain becomes highly susceptible to any secondary injury, so you really want to know if you had a concussion. That's something you need to be aware of so you can be hyper vigilant in the immediate future. Make sure that you don't keep putting your brain back out in harm's way. Or if you're sure you've had a concussion, find out just how serious it is. So researchers at Orlando Health in Florida confirmed earlier this year that this aforementioned biomarker can be identified in the bloodstream. It stays in the bloodstream for up to a week, and it allows doctors to identify whether concussions happen from a simple blood test rather than the current standard of care, which is computerized tomography, a CT scan as it's called, which has the downside of applying radiation straight to the brain, not something you want to do any more of than you need to. And so this blood test might be an effective workaround to avoid that. Researchers analyzed almost 600 patients over the course of about 3 years, and they found that this blood test was able to detect mild to moderate traumatic brain lesions with up to 97% accuracy in adults. According to one of the lead researchers, physicians really want to minimize the amount of computerized tomography scans in patients, especially children who are a lot more sensitive to radiation and the side effects that can come with it. Fortunately, this simple blood test appears to give us nearly the same information as a CT scan. This could ultimately change the way that we diagnose concussions, not only in children, but in anyone who sustains a head injury.
We like to think of ourselves as a digital speakeasy for brain hackers, but you can call us Smart Drug Smarts.
Okay, you heard it. That was our entire episode number 152, Halloween 2016 Special Edition, which can be found online along with the links to everything that we talked about here at smartdrugsmarts.com/152. If you missed last week's episode number 151, we talked about white noise, that hissy, staticky sound that somewhat surprisingly can have cognitive benefits for a lot of people, but some people more than others. I will not rehash that episode now, but if you missed that, you might want to go back and check it out. Next week, I think we'll be getting back to our roots, talking about something chemical in nature. We've got lithium, Vitex, Debinone, a handful of chemical episodes on tap coming up soon. We're in the lucky situation of having a bit of an interview backlog at the moment, which is by no means a bad thing. In any event, we'll get going for now, but hope to see you back here next week. Same time, same podcast, and with the same unflagging commitment to helping you fine-tune the performance of your own brain. Have a great week, and stay smart.
You've been listening to the Smart Drug Smarts podcast. Visit us online at www.smartdrugsmarts.com and subscribe to our mailing list to keep your neurons buzzing with the latest in brain optimization. Smart Drug Smarts should be listened to for entertainment purposes only, although some guests on the show are medical doctors, most are not, and the host is just some random guy. Nothing you hear on this podcast or read at smartdrugsmarts.com should be considered medical advice. Consult your doctor and use some damn common sense before doing anything you think might have a lasting impact on your brain.